Thank you. You are too kind for me. Thank you so much. So let's start since I have a lot of slides, but I will skip some because I tend to abound about that. Thank you for coming. Work, yeah, in a big numbers, and it's really a pleasure to speak in such a huge audience, and we really enjoyed it. So this is a work that we did together, the EANM Technologists Committee, together with the University of Salford. Here are the list of participants to this kind of work. So no disclosure to say. So the learning objectives are, we start with basic principles about dose optimization in Europe. Some talks about European guidelines. We will talk about a UK research project on cardiac nuclear medicine, some definition and role of EANM, some dedicated project from EANM, technology's involvement in this, a conclusion point, and hopefully some discussion about it. So, what's about justification? Medical exposure shall show a sufficient net benefit, weighting at the total potential diagnostic or therapeutic benefit it produces. So what does it mean, justification in nuclear medicine? That every time we put the patients under some ionization duration or inject some radionuclides in him, we have to justify why we do it. The other point about dose reduction is optimization. So we use the principle ALARA. Each medical procedure involving radiation exposure must be kept as low as reasonably achievable, consistent with obtaining the required diagnostic information. What does it mean? That we have to promote the establishment of a diagnostic reference level, and we have to use a proper optimization of imaging system. We have to work in a competent, and also we have good technologies to do our job. What is the effective dose? It's the sum of the dose to a number of body tissue, where the weighting factor for each tissue depends upon its relatively sensitive to radiation-induced cancer. A single dose estimate related to the total radiation risk. So what does it mean? It means that we need to know how really we can damage the patient without exposure. Here are some typical effective dose. So you can see what's happening is about diagnostic radiographic examination, and you can see how it compared with the approximate equivalent for natural background. So for example, if you have just a chest PA scan, is about 3 days of natural background. If you have a CT of abdominal pelvis, it's just like 4 or 5 years from natural background. So you can just check the impact of what we are giving to patients. The same can be said about what's happening in with radionuclide studies. So you can check that what a lung ventilation is just 7 weeks of natural background, and PET brain is 2 or 3 years. You can also check the equivalent for chest radiographers. So a PET with FDG is about more than 200 of chest radiography. This comes the principle, justification and optimization. We have some referring guidelines in Europe, like coming from the Council Directive, coming from EIA, and also we have EANM guidelines that assist in practice of performing, interpreting, and reporting nuclear medicine procedures. What does it mean? From the European Council, we have some principle to say, some legal issues. EANM, as the umbrella organization, is taking on this one and putting them into nuclear medicine, trying to have the best practice possible to apply these principles. So, the use of radiological investigation is justified in terms of clear clinical benefits to the patient. We should outweigh the small radiation risks. So, diagnostic medical exposure at about 1/6 to the population dose from background radiation. And now, with the increase of diagnostic procedures in all the Western countries and all the Eastern, and now in every part of the world, we are giving a more dose than we used to be. So we have to face it. So what does it state, Euratom? Reduce unnecessary exposure of patient to radiation. Responsible organization individuals using radiation must comply with this regulation. And this is really important. We have to avoid undertaking investigations unnecessarily. It's really important also for technologists to say one is an exam is not appropriate to state that. So the primary goal is to improve clinical practice. Assimilate, evaluate, and implement the ever-increasing amount of evidence opinion on current best practice. Reduce the number of referrals. So the final goal is to reduce medical exposure to radiation. Then we go quite more in practice. Why we choose to talk about MPI? Because there is one where we have more data. The first is that we have two types of radiopharmaceutical, mainly there's Tetrafosmin and Sestamibi. We can have two types of protocols, one on 2 days. And we take a secondary data from peer review and grey literature. There is plenty of it. We have a lot of DRLs to identify how much dose is given to patients. And then what we did, we calculated the effective dose. And we estimated the risk of developing cancer. So we did not just state how much activity we inject to the patient, but how much really can be dangerous to patients. That's why we did our type of work. We included 37 European countries and also US. They were very kind to give us data. So you can check some DRLs that we used. So EANM, what is written in the guideline for EANM. You can see. You can see what we use, what is suggested to give for 1 and 2 days protocol, how much activity we are really giving, and which are the critical organ to be. And this is with the effective dose in millisievert for the 70 kilo patients. Well, let's compare it a little bit with another countries like German. You can see that, well, we are quite the same with the 1 day protocol on stress test. We are stating as much as the same effective dose for the patient. So we can state that EANM guidelines is quite followed in Germany for what is written. Results. You can say there is some differences between countries. And in 1 day countries, 7 countries higher than one standard deviation respect to mean. And 2 days protocol, just 1 country. This is worked about Sestamibi. So what does it mean? There are 37, much of them are quite in the middle of our data. The change is not changed too much between one country and another. This is about Tetrafosmin. So 7 countries are higher, with quite the same results as you can see. And 1 country is out, but it's a different country. So we have another different countries. Also in the 2 days protocol is there. But we can state that quite in 2 days protocols is more uniform, the quantity of effective dose given by patients. So what do we consider? Trend, there's a reduction in megabecquerel used since 19th. And some countries really use much lower activities than others. Risk is higher in female and much higher in younger female. And there's some differences between the 2 isotopes exist. So tetrafosmin we found out as a lower risk. Actually, this study has some limitation. We have to state that. Not all countries have publication with DRLs. So pan-European documents were used to fill the gaps. So to state with some countries we didn't have it, we assumed that they were used pan-European documentation. And data quality is a problem. So some publications are not clear about how much dose is given for 1 day despite 2 days protocols. What we are stating after that? Well, we just gave an example of what's happening. And there is a challenge for nuclear medicine dose optimization in Europe. We have a diffusion of multimodality imaging, and technological evolution made some no-dose image technique competitors with nuclear medicine procedures. That's one of the main points of this discussion. Because, well, we have to be competitor with some, like MRI, that give really high quality images without giving those to patients. So we have to face that the hospital may prefer that for that reason. We have to think about it. We have a fight between imaging optimization and dose optimization. We have a lot of legal aspects to face. There is an increased fear in the coming with the internet, with the mass knowledge of radioactivity in population. And usually national legislative organs are really slow against the fast technological advance in imaging. So imaging is really going faster than regulations. And sometimes we have to face in Europe, there is some tension between European Union and some nations. And then can be also slow the process. What is EANM and what is trying to do for that? Well, you know, I told already that is the umbrella organization. Well, aims is advancing education and science in nuclear medicine, and also have also a coordinating work for both diagnosis, treatment, research, and prevention of disease. So EANM is quite like the referral for European Union for everything regarding radionuclide substances. So every problem regarding that is talked with EANM. It's really a first referral. But also it works together with the National Society, and we have more than 3,000 members, including also a lot of technologists, 39 national societies. So we can state that the EANM at now is the largest organization dedicated to nuclear medicine in Europe. So what does it do about that? It organizes guidelines on topic of dose reduction. It can write position documents. Insert the topic in procedure guidelines. So for example, if they are doing an imaging procedure guidelines, we can also talk about dose reduction on that. Make European legislative organs aware of the problematic. So, hey, please, you from the government, check that we are talking about dose optimization and dose reduction. Discuss it with national organization. Discuss it with the related European organization on optimization in multimodality imaging. This is a good point because we also have to talk about that together with the radiation therapist, together with also the radiologist. We cannot be an isol in that. And we have to create tools useful for daily practice. Here are some projects, I will talk about that. One is PedDose.net. It's a project that was funded by European Commission and is mainly related to pediatric. The rationale is since nuclear medicine is start to contribute really to health and to diagnostic procedures in every country in Europe, we have an increase in importance and number of procedures. And so we have an increase of installed positron tomograph and PET-CT system. We have an introduction of new molecules going on and a development in molecular biology and medicine. So, what we want to ask is how this repetitive diagnostic amount of radioactive really impact patients? We don't know actually, because there is a really lack of systematic evaluation. We have a lot of different works, but not a systematic evaluation of what's really going on. So the objective is really have good data, focus on assessing how subdoses were derived and how new developments can change it. Talk about also the pharmacological risk together with the risk from radiation. And so the project is addressed primarily to the risk associated with the use of radiation, ionizing radiation on patients. Here are some of the projects that we follow all the points, like literature reviews, phantoms modeling, and so this is quite all the things that we have done with the PEDOS. But the most important is dissemination. We have to get people aware that we are doing this, and we are trying to really improve in this project. What's really happened in practice? We were able to create a pediatric dosage card. It's quite popular all around Europe because it provides for the quick way to determine radiopharmaceutical activity to inject to children as function of weight. Here you can see it. And you can download it from EANM website if you need it. It's very nice. And we have a revision from a previous one. And we set a minimum of activities. What is the most important thing? Because, well, we tried to have activities to be administered as weight-independent effective dose to children. But what I will state that we introduced a minimum activities to guarantee a minimum standard of image quality and avoids a variety of dose administered. So what we wanted to do, standardize the image quality of patient. Not have some centers that really give less dose, giving really bad images. But as to say, okay, they are children, we want to get safe for them, but still want to have image quality. Remember, the first principle, justification. So there is no justification in giving a dose to a patient that is not able to give a quality image. So some further projects. One I will talk later on during this day is about the RPCT accreditation. That we are, with standardization, we are trying also to low optimize the dose. And well, there is a proposal that's going on about having an app for those two patients, including all the nuclear medicine procedures. We are also involved, and maybe we will insert them in the future tech guide that we are preparing for technologists. It's a project that is going on. We find it really interesting to give also, quite like the pediatric dosage card, but for every nuclear medicine procedure. So let's talk about text a little bit. Role in dose optimization is really dependent on national regulation, but they are fundamental in protocol optimization and dose optimization. Actually, there is a lack of a stated European standard to dose to be administered, and this makes the situation a little bit blurring for techs, because everyone may have a good idea, but there is still not a systematic evaluation of it. So, well, we have what we are to face. There is a challenge coming from hybrid imaging. And it's mainly about CT, because in MR, there are no ionizing radiation performed. So, well, there is a discussion about CT acquisition. Must be only for attenuation correction, or must be only for diagnostic CT? And also there is a challenge, standardization of procedure versus personalized treatment. What does it mean? We have to give weight amount to the patients, or we have to give standards? How we can standardize imaging and standardize dose? It's not so easy. It's really a challenge. Yeah, the certain technologists are professionals that put it to administer dose as ionizing direction. So, well, we have to be involved in optimization because we are the one that push the buttons. So we have to know what we are doing. There must be also interaction with the radiographers and radiologists when we perform CT. We have to face it. Sometimes there is a huge problem. Lobbying go against multidisciplinary discussion. So some economical, political issues go on better than what's really a conflict of ideas. So to conclude, dose optimization is really an important issue. It's really, really an important issue. We request for standard, and every nuclear medicine professional are requesting for standard. But we really need to work about what is going on. Okay. In different countries, we really need a lot of works. And standards will come only after real knowledge of European situation. Actually, we cannot state standard without knowing what really is given to patients. Please, when considering dose optimization, put the patients at the center. We try to do comparative analysis. But EANM has worked on methodology and practical issues, often in cooperation with extra European realities. But we are still at the starting point. A lot of research work is performed through Europe as a showing example. This can be an optimistic view for the future. People are getting aware of it and working hard for that. But still, we need more coordination on a later stage. Thank you very much. Some questions? Thanks.
Thank you very much for your wonderful presentation. I would like to ask about the European dose card. Do you actually use it for only pediatric estimation of the injected dose, or ultimately you can go up to injecting an adult as well?
Actually, the pediatric dosage card is really pediatric, and that's why we set the minimum standard. But we really enjoyed working with it, and so we are really, really trying to update it. But we think that talking about a pediatric is different because you have to set standard also for the image quality. You have to really be able to understand, because we don't know, just too simple talking, pediatric patient can be really huge as me, yeah, or can be a small child, and you have to face it. Pediatric dosage card try to solve this one. For patients, grown-up patients, the principle will be the same, but it is a project that's still ongoing, but we are thinking about it. So I recommend not to use pediatric dosage card as a referral for grown-ups at now. But if you're working...
I think it goes up to 70 kilograms.
Yes.
If you have a child who is 70 kilograms.
It happens. We have the childs of more than 80 kilograms in our department. So we use the adult dose. what we have to think about it. We have really well. The principle must be always talked. There was a discussion in the United States about dose optimization, about the growing bigger and bigger of patients. So, but there was a man saying to me, "What I have to do? I have all patients that are 100 more than 100 kilograms. Yeah, obese patients." And I said to him, "Please give the correct dose. Image quality is the first thing, because without image quality, you are performing an unjustified performance. But also take care not to give a small child a dose of the adult." So that's the principle must be always followed. These are guidelines, but principles are the main things.
But I think even the child with 70 kilograms, still he holds inside the organs that are still sensitive compared to an adult. So
yeah, absolutely. That's why we did it.
Thank you.
Absolutely.
Thank you, Giorgio. I had a curious question. What are you doing with this information? Are you only using this to try and reduce the dose for each scan, or is there a sense of cumulative dose? Because I can tell you in the United States, we now track dose, and it's reportable in the patient's medical record. We try and keep a running tally of how much dose each patient is giving, what kinds of exams. Because there's a big push now, especially in nuclear cardiology, to have more than half of your studies performed under 9 millisieverts. In the United States, that is very challenging. And I was just kind of curious of your thoughts along that.
Well, some projects are not performed only by the tech comms, but we have a dedicated committee dedicated just to dosimetry, so we are there performing that. Yes, what I told you before, in Europe there is the big problem that we are a pool of nations. So we can just state, try to organize, and really difficult to be systematic. And sometimes accountants can do it by themselves. They start project by themselves, looking at what they are doing, but not really looking at the big picture. This is our challenge. Our challenge is to really be able to collect data from all around Europe. Then we put standard points, and that's but what we are stated, like in the work I showed, you put 9 millisieverts, that's good, but we have also to state about effective dose and real risk. So it's really challenging to find the right way to state standards, because you can state standards that are too high or too low, so difficult to achieve. It's really difficult to what we are looking, and those reduction is really a tricky issue. But the big problem is that it's becoming more stressing, the point, because MRI is growing and becoming cheaper, so we have to hurry up on that.
I noticed that you had a big range of variation among the European countries relates to the effective dose in one-day protocol. Do you think is the reason behind that is that the amount of injected dose may be variable within one day if you're going to have a stress and rest at the same time? Or is there other...
I think mainly it depends on the imaging equipment. So the capability to keep low dose with imaging equipment. So for example, the more developed country that has CT SPECT are able to give less dose than the less developed country. So that's why it's my point is about that. And also, well, it's really difficult because every nation really have different regulation. So we have also to check this regulation, but these regulations sometimes are just a referral. We don't know actually the work is made on DRLs, but we really don't know in every center what they are really doing, if they are following or not the DRLs. That's the main point, and that's the main difficulties of this kind of jobs. We tried. It was a starting point. Many people have done it. There are a lot of also in KSNMMI. I see a lot of papers about this or that, but they are quite single paper. What we are trying to do is about a systematic evaluation.